Valvular heart disease. Give a concise definition and general scheme for left-sided valvular heart diseases, etiology, hemodynamics, and general clinical picture. Valvular heart disease, VHD, is any structural or functional abnormality of a valve that impairs forward flow, stenosis, or permits reverse flow, regurgitation. Left-sided VHD common etiologies. 1. Rheumatic, historically most common worldwide, still common in low-middle income countries. 2. Congenital, bicuspid aortic valve, parachute mitral valve, Ludenbacher. 3. Collagen or connective tissue diseases, SLE, RA, Marfan, Ehlers-Danlos. 4. Carcinoid syndrome. Classically affects right-sided valves, TR, PR, because pulmonary metabolism degrades vasoactive substances. Left-sided involvement is rare and suggests longer shunt involvement. Carcinoid causes plaque-like endocardial deposits, serotonin, etc. 5. Relative, functional dilatation of annulus and LV dilation producing functional MR/TR. 6. Infective endocarditis, valve destruction, regurgitation plus minus stenosis from scarring. 7. Iatrogenic or surgical, prosthetic valve dysfunction, post-repair lesions. 8. Degenerative or calcific, elderly AS, calcific MR components. Also listed in the source, Carey-Coombs murmur, acute rheumatic, Austin Flint murmur, severe AR mimicking MS, papillary muscle dysfunction, dissecting aorta, IHSS, HCM, producing subaortic obstruction. General hemodynamics. Principle. Stenosis leads to upstream pressure overload. For example, MS leads to increased LA pressure, leading to pulmonary congestion, leading to pulmonary hypertension, leading to late RSHF. Regurgitation leads to volume overload of the receiving chamber. For example, MR leads to LA dilation. AR leads to LV volume overload, leading to eccentric hypertrophy. Common downstream consequences. Increased LA pressure, leading to pulmonary congestion or hypertension, leading to late RSHF. LSHF may occur, especially with chronic volume overload lesions. Clinical picture, overview. MS, staged progression, leading to increased LA pressure, leading to pulmonary congestion, leading to pulmonary hypertension, leading to late RSHF. AS, syncope, angina, exertional dyspnea, classic triad, any aortic disease, ASAR, angina possible, any regurgitant lesion, ARMR, palpitations, bounding pulse or throbbing, AR, peripheral or high pulse volume signs, MCQ pearls. Stenosis equals pressure overload upstream, regurgitation equals volume overload, carcinoid leads to right valves except if bronchopulmonary tumor or R to L shunt. Carey-Coombs and Austin Flint are specific legacy murmurs to know. Q2. What are the key cardiac examination findings common to valvular disease? Inspection, palpation, percussion, auscultation. Answer. Inspection, palpation. Apex, MS, slapping, weak apex. AS, sustained, forceful apex. AR/MR, hyperdynamic, displaced apex, LV enlargement. Parasternal, heave. RV/ventricular enlargement to parasternal lift. Pulsation in second left ICS suggests pulmonary hypertension. Percussion. Dullness over second left ICS in PHT, RVE. Auscultation. S1, accentuated in MS, soft or weak in MR. S2 may be accentuated pulmonary component with pulmonary hypertension, may be soft or delayed in AS, paradoxical split. Extrasounds. Opening snap, MS. Ejection clicks, valvular opening if present. Gallops, S3, S4 in failure. Carey-Coombs murmur, rheumatic activity. Murmurs typical. Ejection systolic, AS. Pan-systolic, MR/TR. Early diastolic decrescendo, AR. Mid-diastolic rumbling with pre-systolic accentuation, MS. Note, pre-systolic murmur absent in AF. Left-sided murmurs louder on expiration, right-sided murmurs louder on inspiration. MCQ pearls. Opening snap, Distance from S2 inversely related to severity of MS. Pulsus alternans, advanced LV dysfunction, presystolic accentuation lost in AF. Q3. List complications of valvular disease. 12, grouped as in chapter. Answer, grouped. Valvular-related. 3. Calcification, recurrent rheumatic activity, infective endocarditis, rare in pure MS. Left atrial. 3. LA enlargement to compression of lung, dyspnea, cough. Esophagus, dysphagia. Left recurrent laryngeal nerve, hoarseness, Ortner's cardiovocal syndrome. Lung. 3. Pulmonary congestion to hemoptysis, recurrent chest infections, secondary pulmonary embolism from venous thrombus. Heart failure, arrhythmic, and surgical. 2. RSHF and LSHF, except MS primarily causes pulmonary problems, and surgical complications of prosthetic valves, mechanical malfunction, thromboembolism, IE, and hemolytic anemia. MCQ pearls. Ortner syndrome equals hoarseness from LA enlargement. Prosthetic valves, lifelong issues, anticoagulation, mechanical, structural degeneration, tissue.
Q4. What investigations are essential for valvular disease and what key findings are expected? Answer. CXR, chamber enlargement, LA, LV, pulmonary congestion, post-stenotic dilatation, AS, calcification. ECG, chamber enlargement patterns, P mitrale equals M-shaped P for LAE, or P pulmonale for RV strain, arrhythmias, AF common in MS. Echo, 2D/M mode/Doppler/TEE, most important, chamber size, leaflet morphology, stenosis severity, gradients, valve area, regurgitant severity, vena contracta, PISA, regurgitant volume/fraction, pulmonary artery systolic pressure, thrombus in left atrial appendage, TEE. Typical findings: mitral hockey stick anterior leaflet doming in rheumatic MS, reduced E-F slope on M mode. Catheter/angiography, measure pressure gradients when non-invasive results are discordant. Assess coronary anatomy pre-surgery. Other, blood tests baseline, infective workup if endocarditis suspected. MCQ pearls, valve area and gradients from Doppler are central. TEE is test of choice to exclude left atrial appendage thrombus prior to PBMV. Question 5. Outline general treatment options for valvular heart disease, medical, percutaneous, surgical, and key indications. Answer. General measures: treat heart failure, AF, infections, prophylaxis of rheumatic activity, secondary prophylaxis, benzathine penicillin, and targeted therapy of underlying disease. Note, IE antibiotic prophylaxis is now limited to high-risk patients per modern guidelines, not blanket prophylaxis for all murmurs. See EBM note below. Percutaneous/interventional. Percutaneous balloon mitral valvuloplasty, PBMV, for suitable soft rheumatic MS, no left atrial thrombus, no or mild MR, favorable valve morphology/Wilkins score. TAVI, TAVR, for severe symptomatic AS in many patients, initially for high or prohibitive surgical risk, now widely accepted for older patients and selected lower-risk patients, decision by heart team. Transcatheter mitral edge-to-edge repair, TEER/MitraClip, for selected degenerative or functional MR in high surgical risk patients. Emerging transcatheter/tricuspid therapies for severe TR in high-risk patients. Surgical, valve repair, preferred for degenerative MR when feasible, or replacement, tissue or mechanical prosthesis. Indications depend on lesion severity, symptoms, LV size/function, pulmonary pressures, and presence of AF or embolic history. For AS, AVR indicated for severe symptomatic AS or severe AS with LVEF under 50%, or in asymptomatic severe AS with abnormal exercise test or very severe gradients. Heart team decision. TAVI is an alternative to SAVR in many patients, age/risk-based. MCQ Pearls, PBMV is for pure MS with pliable, non-calcified valves and no left atrial thrombus. Wilkins score useful. IE prophylaxis is limited to high-risk patients. Prosthetic valves, prior IE, certain CHD do not use indiscriminately.
Q6, mitral stenosis, MS, anatomy, grading, etiology, hemodynamics, clinical stages, exam, investigations, treatment, detailed. Answer: anatomy and normal MVA. Normal mitral valve area approximately 4 to 6 centimeters squared. Chapter said 4 to 5 centimeters, corrected to textbook range. MS is narrowing of mitral orifice, significant when MVA less than 2.5 centimeters squared, graded mild 1.5 to 2.5 centimeters squared, moderate 1 to 1.0 centimeters squared, severe 1.0 centimeters squared, critical often less than 0.8 centimeters squared. Etiology: rheumatic disease, majority, especially in LMICs, congenital, Ludenbacter equals ASD plus MS, parachute valve, calcific or degenerative, less common for MS. Carey-Coombs murmur is the acute rheumatic stage. Austin-Flint murmur is severe AR producing functional MS-like murmur. Hemodynamics, 4 stages as given. 1. Increased LA pressure with LA dilation. 2. Back pressure into pulmonary veins, pulmonary congestion. 3. Pulmonary hypertension, passive to reactive to obstructive. 4. RSHF, mechanisms of pulmonary hypertension, passive, reactive vasoconstriction, irreversible arteriolar change, or acute, such as a PE. Clinical stages: I. Asymptomatic. 2. Pulmonary congestion symptoms. 3. Pulmonary hypertension signs, LCOP, Malheur flush, giant A waves. 4. RSHF or systemic congestion. Heart rate increasing states such as fever, anemia, pregnancy, and AF, shortened diastole, worsening symptoms. Exam: accentuated S1, opening snap after S2, closer OS to S2 equals more severe, mid-diastolic rumble with presystolic accentuation, absent in AF, stage 3 features of pulmonary hypertension, of ejection systolic pulmonary murmur Graham-Steele. Silent MS may occur with very low flow, concomitant ASD, emphysema, or very high LV pressure. Investigations: CXR, LA enlargement, double density, pulmonary congestion, PA dilation, ECG, P mitrale, AF, RVE later, echo, hockey stick doming essential mitral valve leaflet, restricted posterior mitral valve leaflet, decreased E to F slope on M mode, valve area by planimetry or pressure halftime, TEE to exclude LA thrombus prior to PBMV, cardiac cath sometimes used to confirm gradients or evaluate coronaries pre-surgery. Treatment: medical, diuretics for congestion, rate control for AF or response control, warfarin for AF or prior embolus warfarin, secondary prophylaxis for rheumatic activity by benzathine penicillin, i.e. prophylaxis per guideline indications, not universal. Interventional, PBMV, balloon commissurotomy for suitable pure MS with no or LMR, favorable morphology, no LA thrombus, Wilkins score helps selection. Surgical, valve repair or commissurotomy or valve replacement when PBMV not suitable, heavy calcification, significant MR, LA thrombus, unfavorable anatomy, EBM and guideline notes. TEE required to rule out LA thrombus prior to PBMV. Anticoagulation, warfarin remains standard for AF with rheumatic MS. DOACs generally not recommended in moderate to severe MS per current guidance. MCQ Pearls, OS timing from S2 equals severity, PBMV contraindicated with LA thrombus or severe MR, rheumatic MS common in women and occurs years after acute rheumatic fever. Q7. Mitral regurgitation, or MR. Etiology, hemodynamics, clinical features, exam, investigations, treatment. Answer. Etiology. Rheumatic, common in endemic areas, congenital, connective tissue disorders, infective endocarditis, surgical, post-repair dehiscence, MVP, papillary muscle dysfunction or rupture post-MI, functional MR due to LV dilation, ischemic or non-ischemic cardiomyopathy, hemodynamics, systolic regurgitation, LV to LA, LA dilation, diastolic, increased transmitral flow, LV volume overload and eccentric dilation, acute MR, papillary muscle rupture, i.e., sudden increase LAP, pulmonary edema, or cardiogenic shock because LA cannot dilate acutely. Clinical, often asymptomatic for years, palpitations, throbbing, exertional dyspnea, later L/H symptoms, acute MR, pulmonary edema, and cardiogenic shock. Exam, hyperdynamic displaced apex, systolic thrill at apex, S1 soft, pansystolic blowing murmur best at apex, radiating to axilla. Posterior leaflet MR may radiate differently. Relative or functional MS, mid-diastolic murmur, may appear due to high flow. Investigations. Echo quantifies MR, vena contracta, PISA, regurgitant volume or fraction, LV size and function, pulmonary pressures. CXR shows LV enlargement. ECG for AF or other arrhythmias. Cath if coronary evaluation pre-op. Treatment. Medical therapy for HF as per guidelines. Afterload reduction, vasodilators, can reduce regurgitant fraction in chronic MR. Definitive, valve repair, preferred when feasible, or replacement. Acute severe MR often requires urgent surgery. For functional secondary MR, guideline-directed medical therapy and devices, CRT, may improve regurgitation. MitraClip, TEER, is indicated in selected high-risk patients. MCQ pearls, MR radiation to axilla, classical. Acute severe MR to flash pulmonary edema and hypotension, urgent surgery often needed. Repair preferred over replacement for degenerative MR when feasible. Q9, mitral valve prolapse, MVP. Definition, etiology, presentation, exam, management. Answer. Definition, systolic billowing or prolapse of one or both mitral leaflets into LA during systole. Causes, idiopathic, most common, young females, connective tissue disorders, Marfan's Ehlers-Danlos, muscular dystrophies, congenital, ASD, post-MI or post-surgical. Presentation, often asymptomatic, atypical chest pain, left submammary stabbing or substernal, palpitations or arrhythmias, syncope rarely, sudden death extremely rare. Exam, mid-systolic click plus late systolic murmur, MR. Click timing changes with maneuvers, earlier with squatting, later with Valsalva. Remember physiology. Valsalva decreases venous return. Click occurs earlier or later. Exam focus. Click occurs later with increased LV volume, squatting, and earlier with decreased LV volume, standing or Valsalva. Echo, diagnostic. Treatment, reassurance for asymptomatic, beta blockers for palpitations or anxiety. Prophylaxis for SBE is not routinely recommended, only in high-risk scenarios per modern guidelines. Severe MR may need surgical repair or replacement. MCQ pearls, mid-systolic click, MVP. SBE prophylaxis not routine, limited to high-risk patients.
Q9, aortic stenosis, AS, anatomy, etiology, hemodynamics, clinical triad, exam, investigations, treatment. Answer. Anatomy and surface area. Normal aortic valve area, approximately 3 to 4 centimeters squared. Severe AS, typically less than 1.0 centimeters squared. Some texts use less than 0.8 centimeters squared as critical. Bicuspid aortic valve present in approximately 1% and predisposes to early AS. Etiology: calcific degenerative, elderly, congenital, bicuspid, rheumatic, sub- or supravalvular, rare, hypertrophic obstructive cardiomyopathy, dynamic outflow. Hemodynamics: fixed LV outflow obstruction leads to LV systolic pressure increase. Concentric LV hypertrophy and eventual LV dysfunction, low CO, exertional syncope, angina and dyspnea are typical. Clinical triad: angina, syncope, exercise, heart failure is classic for severe symptomatic AS. Pulsus parvus et tardus is characteristic. Exam: sustained, forceful apex, LVH, systolic thrill at right second ICS, harsh crescendo-decrescendo ejection systolic murmur radiating to carotids. Ejection click may be present, which disappears with severe calcification. S2, soft or delayed or paradoxical split. Investigations: CXR, LV enlargement, post-stenotic aortic root dilation, calcification. ECG, LVH, echo, quantifies severity by AVA, mean and peak gradients. Valve area less than 1.0 cm squared severe, less than 0.8 cm squared critical. Cath is used when imaging discordant or for coronary eval. Treatment: surgical AVR or TAVI based on age, anatomy, and surgical risk. TAVI indications have expanded into many intermediate or low-risk groups after RCTs and guideline updates. Heart team decision is required. Symptomatic severe AS requires valve intervention. Medical therapy, beta blockers for angina symptomatic relief, may be used cautiously. MCQ pearls: triad equals angina, syncope, breathlessness. Pulsus parvus et tardus classic, TAVI increasingly used, check heart team decision. Q10, aortic regurgitation, AR, causes, hemodynamics, clinical features, peripheral signs, exam, treatment. Answer: etiology: rheumatic, congenital, bicuspid, infective endocarditis, dissection, Marfan syndrome, ankylosing spondylitis, syphilis, historically, severe hypertension, post-surgical. Hemodynamics: diastolic backflow from aorta to LV volume overload leading to eccentric LV hypertrophy and increased stroke volume. High systolic BP, low diastolic BP, wide pulse pressure. Chronic AR leads to compensatory LV dilation. Acute AR leads to sudden volume load, leading to pulmonary edema and low forward output. Clinical: early asymptomatic, bounding pulse, palpitations, pleasurable throbbing, exertional dyspnea, angina, from decreased diastolic coronary perfusion and increased LVO2 demand. Angina of Lewis equals nocturnal prolonged angina with autonomic features. Peripheral or high pulse volume signs, classic: de Musset, head bobbing, Corrigan's, waterhammer carotid, pistol shot femoral sounds, de Rosier sign, femoral systolic diastolic murmur on compression, Hill's sign, large SBP difference, leg greater than arm. Pulsus bispherians, double systolic peak, may be seen in AR. Combined AS plus AR and HCM. Exam: high stroke volume leads to hyperdynamic apex. Early diastolic decrescendo blowing murmur best at L3-ICS, A2 area leaning forward. Austin Flint murmur, low-pitched mid-diastolic when severe AR causes functional MS-type murmur at the apex. S2 often normal or soft.
Investigations and treatment: echo quantifies regurgitation and LV dimensions. CXR and cath as needed. Medical therapy for afterload reduction, vasodilators may be temporizing. Definitive therapy, AVR or replacement for symptomatic severe AR or asymptomatic with LV dysfunction or enlargement. TAVI not routine for AR, device anchoring issues, but selected transcatheter approaches are being explored. Rheumatic versus syphilitic AR historically differ, age, aneurysm. MCQ pearls, wide pulse pressure, Corrigan sign, de Musset. Acute AR to flash pulmonary edema and hypotension, _25 line, Q11 _TS and TR key points. Answer: TS usually rheumatic and often coexists with left-sided valve disease. Hemodynamics, up RA pressure to systemic venous congestion, down RV filling to low CO. Signs, giant A waves if sinus rhythm, presystolic murmur at lower left sternal border that increases with inspiration. Investigations, CXR ECG show RA-RV enlargement, echo diagnostic. Treatment, valve replacement if severe. TR, usually functional, annular dilation from RVE or pulmonary hypertension or organic, i.e. carcinoid. Hemodynamics, systolic regurgitation RV to RA to systemic congestion, JVP with systolic pulsations, pulsatile hepatomegaly ascites, often before peripheral edema. Exam, pansystolic murmur at left lower sternal edge, increase with inspiration, thrill possible. Complications, RSHF, cardiac cirrhosis, i.e. Treatment, treat underlying cause, diuretics, and surgical or percutaneous intervention in severe symptomatic cases, valve repair or replacement. Emerging transcatheter options exist for inoperable patients. MCQ pearls, TR murmur increases with inspiration, Rivero-Carvalho sign, pulsatile hepatomegaly equals TR. _25 line Q12, quick clinical murmur localization and propagation, rapid recall. Answer from chapter cleaned. Systolic murmurs commonly heard over base, AS, PS, MR, TS, VSD, PDA, coarctation, collateral flow. Over apex, MR, and lesions propagated from other areas. Diastolic murmurs over base, AR, PR, MS, TS, PDA. Over apex, MS, organic or relative. Useful rapid list for OSCE or short answer. MCQ pearls, left-sided murmurs, louder on expiration, right-sided mounder on inspiration.
Fast, high-yield MCQ notes, one-line bullets. MS severity, MVA less than 1 centimeter square equals severe. Less than 0.8 centimeters square equals critical. OS nearer to S2, more severe. MR murmur, pansystolic, apex to axilla, radiation to base if posterior leaflet disease. AS severe, AVA less than 1 centimeter square, symptoms equal angina, syncope, heart failure, urgent valve intervention indicated. AR peripheral signs, Demusset, Corrigan, pistol shot femoral, de Rosiers, Hill sign, LLSBP greater than ULSBP. Carcinoid, TR and PR right valves due to serotonin plaques, flushing and diarrhea, pulmonary metabolism protects the left side unless shunt. PBMV indications, symptomatic, moderate to severe rheumatic MS with pliable valve, no LA thrombus, MR less than 1+. TEE is mandatory to exclude LA appendage thrombus before PBMV. Anticoagulation in rheumatic MS plus AF, VKAs, warfarin, preferred, DOACs are not recommended for moderate to severe MS per current guidance. IE prophylaxis is limited to high-risk groups, prosthetic valves, prior IE, certain CHD, cardiac transplant recipients with valvulopathy, not for all patients with murmurs. Legacy lecture note, older texts taught wider use, update your practice exam answers accordingly. TAVI, now an established option for many patients with severe AS. Heart team selection. TAVI expanded beyond prohibitive risk to many older or lower risk patients per 2020-2021 guidelines. Transcatheter mitral TEER, MitraClip, indicated for selected degenerative or functional MR in high surgical risk, expanding evidence and indications. Legacy versus updated practice, flagged. Legacy, blanket SBE prophylaxis for many valve lesions. Updated, prophylaxis restricted to high-risk groups only. Legacy, DOACs acceptable for all AF patients. Updated, DOACs are not recommended for moderate to severe rheumatic MS, warfarin preferred, emerging trials are ongoing, follow guideline statements. Legacy, TAVI only for inoperable or high risk. Updated, TAVI has expanded indications depending on age, anatomy, and risk, shared decision by heart team required. One page must memorize crib sheet. Stenosis equals upstream pressure overload. Regurgitation equals volume overload. MS, rheumatic, MVA grading, OS timing, PBMV indications, LA thrombus, anticoagulate, and no PBMV. MR, acute versus chronic. Acute equals pulmonary edema or shock. Apex to axilla, pansystolic. Repair greater than replace when feasible. MVP, click, to late systolic murmur, reassure, beta blockers for symptoms, no routine IE prophylaxis. AS, triad equals angina, syncope, dyspnea, AVA less than 1 centimeter square, severe, TAVI or SAVR per heart team. AR, high pulse pressure, Demusset, Corrigan, Austin Flint, surgery if symptomatic or LV dilatation or dysfunction. TR or TS, often functional, TR increase with inspiration, pulsatile hepatomegaly, JVP systolic waves. Suggested essay questions. 1. Define valvular heart disease and outline the etiologies, hemodynamics, and general clinical approach to left-sided valvular lesions. 2. Describe the pathophysiology, clinical features, investigation, and management of mitral stenosis. Include indications for balloon valvuloplasty and surgical intervention. 3. Discuss mitral regurgitation, causes, acute versus chronic presentation, investigation and indications for repair versus replacement. 4. Explain mitral valve prolapse, clinical features, murmur dynamics, investigation and management. 5. Outline aortic stenosis, epidemiology, classic triad, physical signs, investigation thresholds for intervention, and current options including TAVI. 6. Describe aortic regurgitation, causes, peripheral signs, hemodynamics, emergency presentation, and indications for surgery. 7. Discuss tricuspid valve disease, stenosis or regurgitation, causes, signs, and management priorities. 8. List common valvular murmurs and their localization and propagation with an explanation of inspiratory and expiratory variations. 9. Discuss complications of valvular disease, prophylaxis, rheumatic or IE, and key updates in valve disease management, TAVI, mitro-TEER, and anticoagulation in rheumatic MS. 10. Describe how to approach a patient with suspected severe valvular disease in the emergency room, acute MR, acute AR, decompensated AS.